This eMultipleSclerosis review program is presented by DKB Med Radio.
I think CAR T may be reserved for people with MS with really highly active inflammatory activity despite disease-modifying therapies. This is similar to how we think about using hematopoietic stem cell transplant in people with highly active MS.
Promising new options in MS care. Welcome to eMultipleSclerosis Review. CAR T-cell therapies, BTKI. These approaches have proven successful in treating other diseases, and they're now being investigated for benefits in multiple sclerosis. What's the evidence showing? How effective are these medicines? Do they slow clinical progression? How safe are they? What's known about their potential side effects? Which types of MS are they likely to be most appropriate for? And most importantly, how can clinicians use these findings to improve their patients' lives? To help increase our understanding, we're joined today by two guests from the Department of Neurology at The Ohio State University Wexner Medical Center in Columbus, Ohio. Dr. Cole Harrington, an assistant professor, and Dr. Nikhil Modak, a neuroimmunology fellow. For our guest disclosures and additional CME information, please go to our website, emsreview.org, and select the Volume 6, Issue 8 link. I'm Bob Busker, Executive Producer of DKP Med's e-literature review video programs. Dr. Harrington, Dr. Modak, thank you both for joining us today.
Hi, Bob. Thanks for inviting me. I'm glad to talk to you today.
It's great to be here. Thank you for the invitation.
Our overall learning objective for this program is to describe safety and efficacy of treatments for MS that are newly available or in development. Our first focus, and our initial topic of conversation, is to describe the results BTK inhibitors have demonstrated for slowing MS clinical progression and reducing new or enlarging lesions. So, that being said, if you would please, Dr. Harrington, take us to the clinic and start us out with a patient scenario.
So we have a person living with MS who is 45 years old, diagnosed with relapsing MS in their 20s. They had highly active MS at the diagnosis with multiple relapses and breakthrough lesions on several oral therapies. This included fumarates as well as S1P modulators during the first 15 years of their MS. Their last relapse was 10 years ago at 35 years old while on a fumarate. Since that relapse, they've had several breakthrough lesions on the fumarates, causing them to switch to B-cell depletion agent about 5 years ago at age 40. Since their last relapse at 35 years old, they've required a cane now for mobility. Their current MRI shows a high lesion burden with several expanding lesions over the past couple of years. Recently, the foot drop has been worsening over the past year, and they are considering using a walker when going out for increased risk of falls.
It would seem that in the 20-plus years since their original diagnosis, this patient's relapsing MS may have become progressive. Do you agree, Dr. Harrington?
Yes, their clinical history supports a transition from relapsing to progressive MS with the worsening foot drop and increased need for assistive device. They are on B-cell depletion and have had expanding lesions despite this.
What are your thoughts on treatment, doctor?
We might consider a BTK inhibitor when commercially available for this patient, with the recent clinical trial results from the Hercules trial indicating that slowing of progression and non-relapsing secondary progressive MS with tolebrutinib. We could also consider adjusting some of the symptomatic medications or adjunctive therapies to target their symptoms that may be impairing the gait, such as spasticity, by increasing baclofen or a trial of Botox, and also referring to physical therapy for assistive devices such as an AFO or a rollator.
This tolebrutinib Hercules trial, Dr. Modak, is our patient similar to the secondary progressive MS patients enrolled?
That's a great question. The answer is yes. In terms of inclusion criteria for the trial, they are within the age range of 18 to 60 years old. They have non-relapsing secondary progressive MS with 1 year of worsening gait and an increase in EDSS score over the past year, and an EDSS score within the range of the study, which is from 3 to 6.5, with 6.5 indicating a need for bilateral assistance for 20 meters walking and no relapses in the past 2 years. In terms of trial demographics, the average age is 49 years old, with about 60% women. mean EDSS of 5.5, so walking 100 meters without aid or resting, and disability precluding full daily activities, and an average time since MS onset of about 17 years, and average time since last relapse of about 7 years.
Dr. Harrington, the outcomes the researchers assessed in this trial, what can you tell us about those?
In this trial, patients were randomized to tolebrutinib or placebo and followed with exams every 3 months and MRIs every 6 months for 2 to 4 years. The primary outcome was time to onset of 6 months of confirmed disability progression for people with an EDSS score of 5 or less. So this means the ability to walk 200 meters without rest or aid, but disability impairs full daily activities. And this was defined as an increase of 1 point or greater above that score, baseline score. For example, if an EDSS was 5, going from 200 meters unassisted to needing to walk with a cane for 100 meters, that would be an EDSS of 6. This would be defined as a 1 point increase in confirmed disability progression. For people with an EDSS of greater than 5, a 0.5 point or greater change was the cutoff for confirming disability progression instead of 1 point. And 2 other outcomes, secondary outcomes, were assessed, which were the total number of new or enlarging T2 lesions and the percent change in brain volume.
And the results, doctor, talk to us about those if you would, please.
Yes, the results from the trial and the primary endpoint of 6-month disability progression were positive, indicating a 31% risk reduction of 6-month disability progression in tolebrutinib compared to placebo. Newer enlarging T2 lesions were also significantly reduced, from approximately 3 newer enlarging lesions per year in placebo compared to about 2 in tolebrutinib. Brain volume loss was not significantly reduced in tolebrutinib compared to placebo.
Hypothetically, let's say this patient we've been discussing was switched from the B-cell depletion agent he's been on for the last 5 years to a BTK inhibitor like tolebrutinib. What would you expect to see with that?
This is a difficult question to answer, as none of the trials, either the relapsing trial or the progressive trial in MS, have compared BTK inhibitors versus B-cell depletion. There's one ongoing trial in primary progressive MS called FENtrepid that's comparing the BTKI fenebrutinib versus ocrelizumab. There's also an ongoing 4-year trial investigating ocrelizumab in primary and secondary progressive MS that may offer some insight into clinical and radiologically outcomes in people with progressive MS on B-cell depletion. And data from this trial may offer some insight into how B-cell depletion compares to BTK inhibitors in progressive MS.
Thank you, Dr. Harrington. Dr. Modak, in people with relapsing MS, what's the data been showing about the effects of BTK inhibitors?
Sure, let's talk about that a little bit. The results of 2 phase 3 clinical trials, Evolution RMS 1 and 2, with around 2,000 relapsing remitting MS patients, have been published comparing BTK inhibitor evobrutinib to teriflunomide in relapsing MS. They did not show superiority of evobrutinib in reducing annualized relapse rate, new enhancing lesions, new or enlarging lesions, or disability progression. Of note, though, the annualized relapse rates were low in these studies, which corresponds to real-world recent data from the MS-based registry, showing a decline in disease activity with the availability of higher efficacy DMTs. The low relapse rate does reduce the power of the ability to detect differences in relapsing remitting MS and leads to questions about whether relapse rate is an effective endpoint to assess in future therapy trials in relapsing remitting MS. For tolebrutinib, there are also 2 phase 3 clinical trials in relapsing remitting MS, Gemini 1 and 2, which were recently announced with about 2,000 patients as well, comparing tolebrutinib to teriflunomide. Patients in these trials had similar demographics, MS disease duration, number of relapses, and EDSS scores as those in the evobrutinib trials. And tolebrutinib did not significantly reduce the annualized relapse rate compared to teriflunomide, but it did demonstrate a significantly reduced risk of disability worsening compared to teriflunomide. Both trials demonstrated reduced new GAD-enhancing lesions in tolebrutinib compared to teriflunomide, and one trial has demonstrated a significant reduction in brain volume loss over time in tolebrutinib compared to teriflunomide.
What additional research is going on for BTK inhibitors and managing MS?
So, in addition to tolebrutinib and evobrutinib, there are four other BTK inhibitors in clinical trials for MS right now. They include fenebrutinib, remibrutinib, orelabrutinib, and BIB-091. While most of the research reported right now is preclinical, some of these agents do show potential for use in MS.
And would you expect that potential to make its way into clinical use for both progressive and relapsing MS in the relatively near future?
Yeah, I think so. I think the results from progressive MS trials compared to relapsing MS and BTK inhibitors has offered some insight as well into the need to modify trial outcomes in relapsing and progressive trials to include more sensitive outcomes for progression, such as brain and spinal cord atrophy, thalamic volumes, slowly expanding lesions, and phase rim lesions.
Good point, Dr. Modak. Thank you. Our key focus for this part of our discussion is to describe the results BTK inhibitors have demonstrated for slowing MS clinical progression and reducing new or enlarging lesions. Dr. Harrington, what are the most important things you'd want our learners to understand?
Yeah, and the most important points are number one, in clinical trials of progressive MS, the BTK inhibitor tolebrutinib has shown evidence in reducing disability progression and in reducing new or enlarging lesions. Number two, in relapsing MS, the BTK inhibitors tolebrutinib and evobrutinib did not reduce annualized relapse rates, but in the tolebrutinib trial, there was reduced rates of brain atrophy and also reduced disability worsening compared to teriflunomide. Number three, while BTK inhibitors have not been compared to B cell depletion in progressive MS, there is one ongoing trial with fenebrutinib that is comparing it to ocrelizumab in primary progressive MS. And number four, additional measures of progression and disease activity may need to be incorporated into future relapsing remitting trials with the low rates of relapses with more effective DMTs.
Thank you, doctors. And we'll return with our guests from the Department of Neurology at The Ohio State University, Wexner Medical Center in Columbus, in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eMultipleSclerosis review program. Our overall learning objective is to describe the safety and efficacy of treatments for MS that are newly available or in development. We've been speaking with Dr. Cole Harrington and Dr. Nikhil Modak from the Department of Neurology at The Ohio State University Wexner Medical Center in Columbus about the promising results BTK inhibitors have demonstrated for slowing MS clinical progression and reducing new or enlarging lesions. Let's turn now to our program's second key learning focus. Discuss the current findings of the anti-CD19 CAR T cells that are in phase 1 clinical trials for relapsing and progressive MS. So if you would please, Dr. Modak, take us back to the clinic with another patient scenario.
Absolutely. We have a person with MS who is in their 30s with no clinical signs of progression and an EDSS score of 3, meaning that they are fully ambulatory despite signs of severe disability. They were diagnosed 10 years ago and have had very active disease with several relapses and breakthrough lesions while treated with different medication classes, fumarates, S1P modulators, and B-cell depleting agents. They are currently on an S1P modulator and have heard about CAR T therapy for cancer and autoimmune disorders and wonder if it may be an option for MS treatment. Their uncle had lymphoma and recently went into remission after CAR T treatment.
Background us, if you would please, Dr. Modak, about what the abbreviation CAR T stands for and what current CAR T treatment involves.
Sure. CAR T stands for chimeric antigen receptor T cell therapy. So it involves using a patient's own T cells and genetically engineering them to express receptors that make the T cells target cells of interest. In treating cancer, the goal is to engineer the T cells to attack the cancer. In autoimmune disorders, though, the goal is to attack the immune cells that are causing damage, such as the B cells. CAR T involves taking T cells out of the body through a procedure called leukapheresis, where white blood cells are separated from the rest of the blood, and that blood is then returned to the circulation. The T cells are then grown in culture, and genetic changes are introduced with viral vectors that are designed to express receptors that target the cell type of interest. These genetically engineered T cells are then reinfused into the person after a course of chemotherapy, which allows for resetting of the immune system.
Thank you, Doctor. Now, specifically, though, in MS, what's the goal of CAR T and how does it work to get there?
That's a wonderful question. In MS, we have autoreactive immune cells, and these include B cells, T cells, and T regulatory cells. These cells can attack our central nervous system or release factors that are damaging or stimulate inflammatory responses. In MS, we already know that B cell depletion with medications like rituximab, ocrelizumab, or ofatumumab are very effective for MS. The CAR T therapy that is currently being investigated in MS involves using CAR T that is directed against CD19 positive B cells. CD19 is expressed on many B cells, including CD20 B cells, which are the targets of these conventional B cell depleting therapies. CD19 allows us to target several other populations that your standard B cell depleting agents do not target, which include the plasmablasts and pro B cells in the bone marrow. Pro B cells are early B cells that go on to make more mature B cells that then migrate out of the bone marrow and into the lymphoid tissues and central nervous system. Plasmablasts are B cells that go on to make plasma cells, which are responsible for secreting antibodies. The goal here with CAR T therapy is to target the CD19 B cells in MS and deplete a broader population of them to potentially better target the central nervous system with cells as opposed to the antibodies.
Nice explanation. Thank you, Dr. Modak. Dr. Harrington, among people with MS, which populations would you expect will most likely benefit from CAR T?
I think it's difficult to know at this point. Anti-CD19 therapy has only been studied in one phase 1 clinical trial for MS with inebilizumab, and anti-CD19 therapies are approved for neuromyelitis optica spectrum disorder. However, pathogenic antibodies are known to have more of a pathogenic role in that disorder compared to MS. And in MS, some types of plasma cells may actually be beneficial.
And what types of patients are these clinical trials recruiting?
Yeah, so the anti-CD19 CAR T clinical trials are primarily targeting people with relapsing and progressive MS who have failed disease-modifying therapies. This is because undergoing the chemotherapy regimen prior to infusion of CAR T comes with its own risks of infections and immunosuppression. And CAR T treatment itself in other disorders has a risk of several toxicities. One, immune effector cell-associated neurotoxicity syndrome, or ICANS, and also cytokine release syndrome, or CRS. These are most described using CAR T treatment in malignancy. And ICANS neurotoxicity can cause confusion, seizures, CNS inflammation, brain swelling, and some neurotoxicities may actually not be reversible, such as neuropathy and movement disorders. And these are commonly seen in CAR T, not necessarily the ones targeting CD19, however. Treatment of these neurotoxicities also involves steroids and sometimes additional immunosuppression. And just to mention that the current phase 1 clinical trials in MS are just investigating the safety and tolerability. And one thing to note is they are not comparing CAR T to another treatment. So these trials will not be able to determine the efficacy in treating MS. And if CAR T appears safe in phase 1 trials, further trials will need to be designed to look at comparators and MS disease outcomes.
So overall, given the risks that you've been talking about, do you expect CAR T will actually be useful for patients with MS?
I think CAR T may be reserved for people with MS with really highly active inflammatory activity, despite disease-modifying therapies. This is similar to how we think about using hematopoietic stem cell transplant in people with highly active MS.
Are there other targets besides CD19 that could be investigated for MS? Your thoughts on that, Dr. Harrington?
Yeah, this is an interesting question. I think there are more unique targets that may provide new mechanisms in treating MS that could be used for future CAR T trials. For example, regulatory T cells or Tregs are a subset of T cells that can suppress or regulate T cell responses, which are involved in the development of autoimmune conditions, which include type 1 diabetes, lupus, inflammatory bowel disease, asthma, graft versus host disease after organ transplant, and MS. And Tregs may be more efficient at migrating to tissue and also recognizing target antigens. For target antigens in MS, if there is also a role for Epstein-Barr virus persistence in B cells, and antigens that are unique to Epstein-Barr virus are present in infected B cells, those could be specifically targeted with CAR T therapy.
Thank you, doctors, for this fascinating glimpse into the potential future of MS management. Our key learning focus for this part of our discussion is to discuss the current findings of the anti-CD19 CAR T cells that are in phase 1 clinical trials for relapsing and progressive MS. So, Dr. Harrington, if you would please, summarize for us the key concepts our learners should take away from this part of our conversation.
Yeah. So number one is that CAR T involves leukapheresis, genetic modulation of T cells, followed by chemotherapy and reinfusion of modified T cells. And number two, anti-CD19 CAR T are the CAR T therapies that are currently in clinical trials for MS. Number three, CD19 is expressed on a broader range of B cells, including plasmablasts and pro B cells. And number four, ICANS is a neurotoxicity that can occur after CAR T therapy and can cause confusion, CNS inflammation, and seizures.
From the Department of Neurology at The Ohio State University Wexner Medical Center in Columbus, Ohio, Dr. Cole Harrington, Dr. Nikhil Modak, thank you for sharing your knowledge and expertise with us in today's eMultiple Sclerosis Review program.
Thank you so much for inviting me.
Of course, thanks so much for having me.
For eMultiple Sclerosis Review, I'm Bob Busker.